All right, everyone, it's noon, so we are going to get started. Thank you all for joining us for today's Spring into Health event. It is our final event in our Spring into Health series in partnership with Prisma Health. So thank you all for joining. My name is Haven Spanier, and I'm the Senior Director of Programming at the U of SC Alumni Association, and it is my pleasure to get to introduce our host today. I do have a few reminders for you all before we get started. So first off, I would like to give a big thank you to Prisma Health for this entire event partnership. It has been wonderful, and I know you all will enjoy today's event as well. Also, we want all of your questions today to make this as interactive as possible. So if you aren't super familiar with Zoom, there's a panel across the bottom of your screen. There's a chat and a Q&A button, so you can type your questions in either one of those, as many as you have, and we will get to as many of those as we can today. But without further ado, I'd love to introduce our host to you all today. Dr. David Amril received his medical degree from the University of South Carolina School of Medicine in Columbia and completed his residency in internal medicine at Wake Forest University Baptist Medical Center in Winston-Salem, North Carolina. He continued his education at Vanderbilt University Medical Center in Nashville, Tennessee, where he completed a fellowship in allergy and immunology. His academic interests include asthma, allergic rhinitis, atopic dermatitis, food allergy, and immunodeficiency. So thank you so much, Dr. Amril, for joining us today. We are very much looking forward to your presentation.
Yeah, thank you. And I'm honored to be here. I'm both a School of Medicine graduate and faculty, so have two reasons for being excited. And this is the end of our kind of spring allergy season. We're kind of getting from our spring into our summer allergy season, so good timing for this. And feel free to type in questions and we'll try to answer as we go along. Or if you have questions at the end, we can address them then. But let's dive right in. So we're going to start just with an overview of, what does it mean to have an allergic disease, and, what is atopy versus allergy. So the common allergic diseases are allergic rhinitis, asthma, eczema or atopic dermatitis, and food allergy. And these are really common chronic illnesses, and most of them are increasing. Eczema is very common in kids now. Food allergy, when I was in grade school growing up, very few of my friends had food allergy. And now like up to, 4 or 5% of children can have food allergy, some of that life-threatening. We've seen allergic rhinitis kind of level off. Asthma has leveled off in some socioeconomic groups, but unfortunately some of the hardest hit continue to have increasing morbidity and mortality with asthma. And we're seeing that in westernized countries, we're seeing this increase of atopic diseases, and they carry substantial healthcare costs and burdens with that. So atopy is a term you may hear. Atopy is the genetic predisposition to be allergic, or when our bodies make IgE against ordinarily harmless things. So normally when our bodies see food and pollen and cat dander, we just make a low-grade response that is doesn't harm us and doesn't do anything. But in people who have this genetic predisposition, they make an allergic response instead. So persons with atopy have this predisposition to make IgE antibodies against all of these common environmental allergens. Now, these pictures are all from the New England Journal of Medicine, and it shows how a host of things, so genetic factors, I won't get into all of these because some of it's a little bit complicated and I don't think necessary for the talk, but a combination of genes and polymorphisms, along with environmental factors, which we'll get into in a minute. And then there's things in our body, like when our skin barrier is not adequate due to eczema, when our gut barrier maybe is not good. And we're seeing a lot of this with the so-called human biome. And we're seeing how the microbes in our gut can help regulate our immune system and probably a lot of other things in our body. And then exposures we have like tobacco smoke in both utero and as in children. Pollutants are very big. Exposure to certain kind of allergens in the household like mold and cockroach and animals can affect this. And all this kind of complicated milieu goes together with that predisposition to be allergic, and it produces what's called Th2 or type 2 mediated allergic inflammation. And as I said earlier, we've seen a big increase in allergic diseases in Western Europe, United States, and Australia. So there appears to be environmental factors, which I just mentioned earlier, which are maybe equally important to the genetic factors. And the thought that a so-called Western lifestyle causes allergies come up. And the thought of the hygiene hypothesis, which is controversial, is that when we're a baby in utero, we need to have kind of a low immune response to our mother. So we have this type 2 or Th2 immune response. But then when we're born, we need to develop a robust, effective immune response to keep us from getting sick. And the thought is with our very kind of clean and antiseptic lifestyle, we're maybe not getting exposed to enough things to help promote a good immune function. That's just one theory. Other theories are that man-made toxins like parabens and phthalates can cause problems. Altered gut biome, this is a huge topic now that we're looking into, is that if you have the wrong types of bacteria in your gut, it could lead to maybe diabetes, autoimmune disease, allergic disease. The overuse of antibiotics, actually right here at USC, I worked with some of the pharmacists and we looked at Medicaid data showing that, or at least suggesting that the use of antibiotics during the first year of life is associated with food allergy. A very sedentary lifestyle, kids aren't playing outside like they used to, getting sunshine and all those outdoor microbes. Maybe increased Sicilian sections could do this because there's microbes in the vaginal tract, which probably help populate a normal gut biome for us. Smoke exposure, other car exposure. Growing up on an interstate, you may actually have more lung disease. So all these theories are kind of looking at why we're seeing this increase in allergic disease in westernized countries. And things that favor a so-called Th1 phenotype, and this is the normal infection fighting phenotype. If you have a lot of older brothers and sisters that make you sick all the time, if you're in daycare getting sick, if you're in third world countries getting tuberculosis, measles, hepatitis, you're more likely to get sick. If you grow up, you're more likely to not have allergies, sorry. If you grow up on a farm where you're drinking unpasteurized milk, you're playing out with farm animals and, playing with cow patties and things, you're less likely to be allergic. And then all these other things on the right side, these actually favor a Th2 or allergic phenotype. So the overuse of antibiotics, maybe our Western diet, being in an environment with toxins and pollutants, and also early sensitization to house dust mites and cockroach may also push us towards this right side with allergic disease. But that said, also vaccination campaigns have been hugely successful. And, with almost eradicating a lot of childhood illnesses, that's much more important than the allergic side. So I'm certainly not saying that vaccines are bad. I'm a very big vaccine proponent. So when we're exposed to common allergens, we inhale pollen and dust mite and cat dander. And most of us have this kind of low-grade response where we make what's called IgG, especially Ig1 and 4. And then these cells make this interferon gamma and these other cytokines like interleukin 10, and these make this low-grade regulatory response. But persons with atopy, they have an exaggerated response where they produce IgE and eosinophils come in and cause inflammation. And this is the hallmark of allergic disease, where you have this infiltration of inflammatory cells like T cells, B cells, mast cells, eosinophils, and they have these type 2 cytokines, interleukin 4, 5, and 13. And this is what leads to the allergic inflammation. And this picture here just shows that it's a very complex interaction where the T cells are like the conductors of the immune system, and these T cells interact with B cells. And then once these B cells are activated, you now produce IgE antibody. This IgE then binds to mast cells and other cells, and this is what leads to our allergic reactions. And once you have preformed IgE on your mast cells, the next time you're exposed to the allergen, whether it's a peanut and you have anaphylaxis, or ragweed and you have hay fever and asthma, it causes this mediated release, again, histamine, leukotrienes, other cytokines, and it causes the effects of asthma, nasal symptoms, even hives and swelling. Okay, so now we're going to kind of get away from some of the basic science and the theory of increasing allergy into kind of the nitty-gritty of allergic rhinitis first. It's a big problem in the US. 10 to 30% of adults and children have it. It's responsible for over 2 million missed school days, and for adults, over 6 million lost work days yearly. And it's also when people are at work and they're suffering from allergies, they have what's called presenteeism, where they're present, but they're not working very well. Over $11 billion in the US, mostly from medications. And it's about 2.5% of all doctors' visits in the US are for allergic rhinitis. But it's actually been around for hundreds of years. So it was first described by Razi. He was a Persian physician, and he had the first complete description of allergic rhinitis with rhinorrhea, congestion, eye symptoms, drainage, sneezing. He had a few things he thought could treat it. He would dip a nose in fabric, and then, dip a fabric in a chemical and put in your nose. Try fumigation of areas. Thought maybe like evil humors in their living area may cause this. Shaving people's heads and rubbing it with mustard and allium, which we've luckily gotten away from. And then also bloodletting, cutting people's ears and foreheads they thought would help. So we've moved on from this, and we have some better treatments now, luckily. So when we use the term rhinitis, that just means nasal symptoms. And the classic allergic rhinitis symptoms are rhinorrhea or runny nose, nasal congestion or stuffiness, excuse me, sneezing, itching of the eyes, nose, palate. People want to scratch deep in their ears and then scratch their palate. Itchy, watery eyes. Often, and fatigue is one of the big things too. People just don't feel well when they have their allergies going on. Now, a lot of people have non-allergic rhinitis with some of the same symptoms of runny nose, congestion, and sneezing, and it can be very hard to distinguish. But they don't have quite as much itching and eye symptoms as people with allergic rhinitis. So this is a nasal endoscopy. We're looking at the mucosa inside the nose. And this is a normal nose. You know, it's pink. It should be some nice mucus here, kind of straining. This is normal. But on the right, you see how swollen it is. So this blood gets engorged in these nasal turbinates. It's kind of pale, almost a bluish tint. You have more mucus. And you can see how there's not much room for airflow to get through there. And this is what leads to that congestion and the head pressure and some of the headaches people get. And then there's something called the Allergic Salute. This girl, people get itchy, they rub their nose in this upward manner, and they can actually get a line, a nasal crease, and that crease can become permanent in some people. These are called allergic shiners. We have these dark circles under your eyes. It's not only associated with allergic rhinitis, but it's a very common feature of it. And then people get really bad eye symptoms in the spring, especially. So here you have the redness of the eyes, the conjunctivitis, and also you have chemosis. You see on this eye, it almost looks like some of the surface is kind of swelling off the eye. That's called chemosis. And this is a really miserable symptom. So we just finished up our tree season here in South Carolina. So the first trees that come out are things like cedar and juniper. And then we move into maple, hickory, and oak. And probably I would say hickory and oak are maybe our two biggest pollen offenders here. Everyone thinks that pine trees are the main cause of allergies. They're big producers of pollen. They put out tons of that yellow pollen that gets on your car, but it's so heavy it falls quickly, and it doesn't cause most of our true allergy symptoms. Actually, it's more of the oak, hickory, maple, birch. I didn't put on here, but birch and elm are big ones too. Cedar, juniper. Now, don't go cutting your trees down, because this pollen can travel dozens, if not hundreds of miles. And so, it's just kind of have to learn to deal with it, but you can't keep your windows closed in your house and your car. So we're just transitioning from our tree season into our grass season. Now, if you're up north, up in like Maine, they're in the height of their tree season right now, but we're kind of getting out of our tree season and into our grass season. We don't have as much Timothy grass here in South Carolina because it's called a northern pasture grass, but we have a lot of Bermuda and Bahia, and that's causing a lot of our symptoms currently. And actually, this is a little more of a, probably like a North Carolina, Tennessee. We could actually shift a lot of our things to the left here, one block. And then there's thought that maybe with, climate change, that we're actually seeing longer and earlier pollen seasons in a lot of regions. And once you get into late summer, you start getting English plantain. And then the kind of the prototypical fall allergen is ragweed. All right, we have ragweed here, but it's worse up in the Midwest and the Northwest. And then, molds can be year-round, especially if you have indoor water damage. And then you do get seasonal spring and fall peaks of outdoor molds, like alternaria as well. So when someone has a symptoms of allergic rhinitis, when they have the runny nose, congestion, sneezing, we can confirm that with either skin testing or blood testing. And they used to call it RAST, but we don't really use a radioallergosorbent test now. It's a little different test, but we can look at blood levels of IgE or skin test. And this is the way we do skin test here. It's called a multi-test. Each of these little heads are dipped into a well with an allergen like dust mite and ragweed or peanut, and it's placed on the skin. And it shouldn't draw blood, but it's just poked into the surface where it just barely gets into the epicutaneous skin. And if that allergen binds to and cross-links the IgE I showed you earlier, you then get a wheel and flare formation. So these are, say this is tree pollen or grass pollen, you have this big itchy wheel and redness. And you measure these tests and it tells you what a patient's allergic to. Now, once you know what they're allergic to and their symptoms, we can treat them with environmental control, medical therapy, medications, and then possibly allergen immunotherapy or allergy shots. And for environmental control, the key is you have to know what they're allergic to. So we usually base this on the skin and the blood testing. And I say it's the mainstay of treatment because you always want to try to avoid medications if possible, but usually it's not that successful actually, because it's hard to avoid things people are allergic to. And some of the main things are dust mites, and you can actually encase your entire pillow, mattress, and box spring in these dust mite proof covers. You can get these at Walmart or Bed Bath & Beyond, Target. And this is what a dust mite looks like. It's a microscope. We don't see them, but they crawl around. They're in our bedding and our carpet. They eat our dead skin. They don't bite us like bed bugs do. They're just kind of cleaning up. They're pretty good little recyclers of our dead skin, but we can be allergic to their body parts and their droppings. Cat dander is a major indoor allergen. Cockroach is really big, especially like for children with asthma. I can see that. And then HEPA filters can help. HEPA filters can sometimes filter out some of the pollen, maybe animals, but with indoor pets, it's pretty tough to get away totally from those symptoms. So the medical therapy, this is probably what you're most interested in, because this is what you can do to make a difference in your symptoms. And many of these are over the counter too. So for allergic rhinitis, we have oral and nasal antihistamines, oral and nasal decongestants like Sudafed and Afrin or pseudoephedrine and oxymetazoline, nasal and ocular mast cell stabilizers, and especially the eye drops I like, I'll get into, Nasal steroids, which are the mainstay, probably the most effective treatment for allergic rhinitis. Some nasal anticholinergic agents I'll mention, and then montelukast or Singulair, the oral leukotrienes. And I want to talk about the ones that we use most commonly. So oral antihistamines are what everyone thinks of when we're treating allergies. Things like loratadine, Zyrtec, or Claritin, cetirizine or Zyrtec, fexofenadine or Allegra. Those are the second generations. Now, the first generations are like chlorpheniramine, diphenhydramine, Benadryl. We try to avoid because of sedation and impairment. And there also is some thought that maybe using a lot of these cholinergic or anticholinergic agents could even lead to dementia later. So we're getting away from those first generation medications. But the oral antihistamines, they're pretty good for the itching, the sneezing, the runny nose, but they do very little for congestion or postnasal drainage. And usually congestion is the main complaint people have. So if you have a lot of congestion, don't expect to get great relief with your Zyrtec or your Claritin. Now you can add an oral decongestant to this, like pseudoephedrine, but you have to watch out for blood pressure, insomnia, sometimes urinary problems at night. And if you want to use Sudafed, it has to be the real pseudoephedrine. You have to get it behind the counter, show your license, because actually people make crystal methamphetamines out of Sudafed. That's why you have to get it behind the counter. But the little red one is 30 milligrams. I like the 120 milligram one better. That's the sustained release 12 hours. So this is pretty good for the mild symptoms, but we can definitely do better. Now, steroid nasal sprays are really the go-to for allergic rhinitis. There's fluticasone, mometasone, budesonide, triamcinolone. That's Flonase, Nasonex, Rhinocort, and then Nasacort. And you can get Flonase, Rhinocort, and Nasacort all over the counter. This is the most effective medication for all the nasal symptoms. But you have to be patient. It may take 1 to 2 weeks to get the full benefit of these medications. So once you do it, it does work as needed a little bit in some studies, but it takes a little while to really get the benefit of it. Some patients can get some nosebleeds or epistaxis. You can also get some irritation and crusting. So sometimes if you do like a little nasal rinse or nasal spray, it can help to prevent the irritation. And also when you use it, you shake it up, put it in very gently and just a tiny bit to the outside and give your spray and sniff lightly. And for adults, I'll do 2 sprays per side, and for children, 1 spray per side. But if you have a lot of symptoms, this is where you want to start. These are all examples of Flonase, Rhinocort, Nasacort. You know, some of these you'll see like children's. There really is no children's version of these. It's just the way it's marketed. It's usually just 1 spray for kids. Now, intranasal antihistamines are really underused. They work better than oral antihistamines with less side effects. They're very effective and they have a quick onset of action within like 15 minutes. And it's actually the only medicine that's shown to be additive to a nasal steroid. So when we add Zyrtec to Flonase, it probably does almost nothing. But adding a nasal antihistamine to your Flonase or Nasonex is additive. The biggest problem is you can only get it with a prescription and they taste pretty bad. The 2 versions are azolastine or Astelin and olopatadine or Patinase. The Astelin is more widely available. It's better covered with insurance, but it tastes pretty rough and it has this really bitter taste to it. Something that if you use a cinnamon sugar-free gum or candy, it can help mask that taste a little bit. But a lot of patients will use a combination of a nasal steroid with a nasal antihistamine, and they actually make a medicine called Dymista that's basically Flonase and Astelin combined that works very well. Eye drops, also underused. So I'm a really big fan of using allergy eye drops. There's nothing better when you've got the red, itchy, watery eyes with allergic rhinitis. There's 2 available over the counter. Olopatadine is now, Patinol, and Ketotifen or Aloe or Zatador. You can do it twice a day. Keep in the fridge, it's cold, it feels even better. And you can also use a re-wetting drop like Blink or Natural Tears or Refresh, and that'll rinse away the allergen and keep your eyes moist. This is one of my go-tos for people that have just runny nose. So an anticholinergic agent like ipratropium is good for clear runny nose, or something called rhinitis medicamentosa. That's when you eat, it can cause running of your nose. And now anyone with spicy foods will do it, but it can happen with any ingestion. And it can be pretty life-altering for people. They don't want to eat with friends because they're embarrassed. But you can just use this ipratropium, one spray up to 3 times a day, and it lasts about 6 or 8 hours. It doesn't cure anything, but it just gives control for 6 or 8 hours. It can cause some drying and crusting, and people do weird things. If you squirt it in your eyes, it can cause blurry vision from the anticholinergic effect. So leukotriene receptor antagonist, montelukast is our main one. We're really getting away from using this. About a year ago, the FDA put a warning out about possible neuropsychiatric side effects with behavior changes, weird dreams, some headaches in kids. And it was shown to be about as effective as Claritin, but not nearly as good as nasal sprays. So I don't do much montelukast or Singul anymore. Some people do great with it, but on average, it's not nearly as good as other options. Okay, so now we're getting to the last treatment of allergic rhinitis, or allergen immunotherapy, or allergy shots. So they found about 100 years ago that if you took grass pollen in someone who's allergic to grass, and if you inject that into that patient with increasing doses, that you can produce long-term relief in their symptoms. And we based it on symptoms as well as both skin or blood tests. And what you do is you make an extract with what they're allergic to. And each week, or even twice a week, you increase that dose. You can't start with the high dose right away because you react to it, what's called anaphylaxis. And even with dosing, you should have anaphylaxis. So it's recommended that you should always get allergy shots in an office setting that can treat allergic reactions. But you build up over several months, and after about 4 to 6 months, you can reach your top dose or maintenance dose. And then if you do that for several years, it can have a long-term disease-modifying response and can help. And also, in addition to injections, we now have FDA-approved sublingual tablets for dust mite, grass, and ragweed. And these are tablets put under your tongue, let it dissolve, and you do it what's called pre-seasonally and co-seasonally for a couple of years, and it can help symptoms. And this is just someone getting their weekly allergy shot here. It's a very small needle. It's the size of an insulin needle like a diabetic uses. Okay, and the thought of allergy shots is that over time, we're training these T cells to, again, get away from the type 2 or Th2 inflammation and shifting over to a normal type 1 or even a better regulatory type thing. So by producing interleukin 10, TGF beta, IgG, and we have less of the IgE and those cytokines involved with allergies. But yeah, I thought it'd be very effective if you use consistently for several years. Okay, and then in addition to allergic rhinitis, I mentioned you can have non-allergic rhinitis. So very similar symptoms, but there's not like a ragweed or a dust mite allergy. What oftentimes bothers people are irritants like tobacco smoke, perfumes, cold air, like you walk into the freezer section, the cold air bothers you. When the air conditioning comes on in your car, it can bother you. Eating, we mentioned earlier, what's called gustatory rhinitis. Weather changes, people they know when a weather front's coming in because they have these increased congestion and drainage. Now, the oral antihistamines are not effective for this, but nasal steroids, nasal antihistamines, which are like your Astilin and Patinase help, and then ipratropium that helps the runny nose. And if you're really stuffy, you can do some Sudafed that can help. And I mentioned at one point nasal decongestants like the Afrin. So Afrin works great. When you do it, you're like, wow, I should have found this years ago, but you can't overuse it. You only want to use the oxymetazoline or Afrin for a few days. because you can get a rebound congestion. It's really hard to get off. Okay, let me see if we have some questions here real quick. Okay, so is there a significant correlation between severe allergic rhinitis and thyroid disease or autoimmune disease? So it's thought that with autoimmune disease, that's not really a IgE mediated or type 2 type inflammation. But we're seeing increases in both autoimmune disease and allergies in westernized countries. So it seems like some of the same things that are leading us to be more allergic are also causing autoimmunity. But they seem to be separate diseases, even though we're seeing more of both of them. Now, there is a link between thyroid disorders, what's called Hashimoto's thyroiditis, and chronic urticaria. But urticaria on a chronic basis is thought to be more of a autoimmune skin disease than true allergies. Let's see. Next question. Is there any long-term health effects using antihistamines daily? We don't think so. As long as they're the newer non-sedating antihistamines. So I'm very safe using Zyrtec, Claritin, Allegra daily in people. And people who have urticaria, I'll use it up to 4 pills a day. That's 4 times FDA-approved dose. But I'm not comfortable doing Benadryl and chlorpheniramine and Atarax hydroxyzine long-term. And those are the so-called first generation sedating ones. Okay, when is Birch season? So we just finished Birch season. Our Birch pollen season is kind of March and April. Now, if you're up north, it's a little bit later. And in some countries, like, if you've ever been to IKEA, it's all birch furniture. So if you're in Sweden, they have these huge birch forests, and then they have a really bad season going into May because it's colder up there. How has climate change impacted allergy seasons? So there's a lot of interest in this. And the thought is that with climate change, now instead of maybe our spring season starting in March, it may be the last week of February. And we are seeing some earlier levels of pollen. And then it may go longer as well, because it's a longer growing season. In some places in like the tropics, their allergic rhinitis is almost a year-round disease. And we may be getting that way here too. Also, we're seeing some things grow that didn't used to grow there. So some of our southern grasses are now starting to grow more up into the mid-Atlantic states. Let's see. What alternatives to pseudoephedrine do we have? So the only good oral decongestant is pseudoephedrine or Sudafed. There's nothing else. Phenylephrine does not work. There's a topical one, Afrin oxymetazoline, which you can use short-term for a few days. But the much better alternative is to use a nasal steroid for congestion, and that can be used long-term. Let's see, if I switch to nasal steroid, do I keep using Claritin? You can. So if you're starting a nasal steroid spray, feel free to use your Claritin as much as you need to. And then as you get better, try to back off and see how you do. There's really no harm to using Claritin with your nasal steroid, but it probably doesn't help that much in addition. So at what age do we expect allergic reactions to increase? So when you say reactions, it depends. If it's allergic rhinitis, kids can get indoor allergy or sensitization like dust mites and animals and mold as early as age 1. But it usually takes 2 or 3 seasons of exposure to get outdoor reactions. So ragweed, grass pollen, tree pollen, usually age 3 and up. And then you can be allergic, or new allergic sensitization all the way up through, your 20s and 30s. Now, if someone's never been allergic in their whole life, like no eczema, no allergies, nothing, and they're 60 or 70, at that point, new onset nasal symptoms probably are non-allergic. It's probably a non-allergic rhinitis. But you can see food allergy in infants, and you can see eczema in infants. We'll see in a minute. Is there a point when we should be tested to determine which allergens? So it's all about quality of life. There's no reason to test just to see what you're allergic to. It's more if your symptoms are affecting your sleep, your leisure activities. If it's interfering with school or work and the medications aren't effective, that's why we get tested. So if annual blood work shows a high level of eosinophils, does this need to be addressed? Well, it depends how high. If it's over 1,500, that is called hypereosinophilic syndrome. So an absolute number over 1,500, not the percentage, but absolute, then that does need to be addressed by somebody. If it's like just a low moderate level, it may mean nothing. If you've got eczema and asthma, it might just be what your levels are. But if it gets very high, then yes, that should be. But 1,500 is considered the marker for severe eosinophilia. Can allergies cause vertigo? That's kind of controversial, vertigo. But some patients who have a lot of congestion, they get a station tube dysfunction, ear fullness, it does seem to cause some balance issues and dizziness in some people. But other things can cause vertigo, like benign positional vertigo or other issues. So that's something to be good to talk to your doctor about. So is Benadryl still best for a severe allergic reaction? So Benadryl was never best for a severe allergic reaction. If someone has a severe allergic reaction to a food or an insect sting, epinephrine is the only acceptable treatment. And it needs to be epinephrine injection in the thigh, like an EpiPen. And that's going to be like with throat, breathing symptoms, passing out, vomiting. Now, if it's a mild reaction, that's where you can use oral antihistamine. So some hives, some mild swelling. I prefer cetirizine. So I don't even use Benadryl anymore. I use Zyrtec personally, but most schools are familiar with Benadryl and they have it available. So in school forms, we use Benadryl. But so acute reactions, Benadryl, Zyrtec, but anything bad, you have to use epinephrine. Can you take Zyrtec for years? There's actually no data or evidence that you get tolerant to an antihistamine. So you can use an antihistamine for years and we don't think you get tachyphylaxis or tolerant to it. What time is best to take Claritin? Doesn't really matter. Some people get a little bit sleepy on Zyrtec, so you can take Zyrtec at night, but Allegra and Claritin just don't seem to cause sedation. So I would just do it when you can remember, or just do it as needed, but it doesn't matter day or night. Is it possible that severe allergies to a bad case of chickenpox? We don't really think there's a link between chickenpox or even a vaccine and allergic rhinitis, so not that I know of. What do you recommend for eczema on the eyes? Actually, we'll get there in a second, so I'll put that on hold. Curious how you advise in all seasons. So if you have allergies during all seasons, you want to use a nasal steroid consistently. And if not controlled, add in a nasal antihistamine. Okay, so we'll answer those, and now we're going to jump over to eczema. So I'm going to have to speed up here a little bit to save time for questions. But eczema or atopic dermatitis, I'm going to use those terms interchangeably. Some call it allergic eczema, but it's all the same for this talk. And it's a combination of an underlying genetic predisposition to have those inflammatory cytokines, and also a skin barrier defect, where you have that rough, dry, scaly skin. You get allergens into the skin as well as irritants, and you lose all your moisture. That's why you're so dry. A filaggrin mutation is an example of one of those skin barrier defects. But dry skin and itching are the hallmarks. You really can't have eczema without itching. And you have these itchy red papules, and you can also get vesicles. Over time, with scratching and trauma, they turn to thickened plaques. You get skin thickening, color changes. You can get both hyper and hypopigmentation, and you get fissures and cracking of the skin. Most eczema starts by preschool. The vast majority of people that have true eczema, it'll start in children. And the typical distribution in babies, it's on the cheeks, and it can almost look like a oozing honey crusted, at least on the cheeks. But as you get older, it settles into the creases of the elbows and the knees, or the neck, the wrists, the ankles, all these flexural creases. Typically, eczema is associated with other allergic diseases. And eczema is the biggest risk factor we know of for food allergy, asthma, and allergic rhinitis. So unfortunately, if you have a child with eczema, especially severe eczema, they're probably going to have some allergy issues as they grow up. Also, eczema can be complicated by infections. You can get impetigo with staph and strep. You get staph abscesses. We see a lot of kids with eczema get staph MRSA abscesses that have to be drained. Also, viruses. You can get more molluscum. You can get something called eczema herpeticum, which can be a very severe infection, and some fungus infections like Malassezia fervor and even other common funguses. So up on the left here, this is kind of a mild to moderate eczema. And you see all these little red bumps or these erythematous papules. You can't help but scratch it. That's why it's excoriated. You know, they've broken the skin here. But in the elbow and the knee creases, it's a very common spot. And this is eczema. One, is a darker skinned individual, but then two, it's more chronic. So the increased scratching has now caused what's called lichenification, this thickening, the scale, the plaques here. And these take even longer to treat. So this is a really severe case of eczema in a baby. So now in babies, you can have this appearance of these honey crusted oozing lesions that are just the eczema. But with this severe case, this is probably super infected. So I would probably call this severe eczema with impetigo. And in this child, you'd be really aggressive in your topical therapy. Plus, I would start them on a oral antibiotic as well to cover staph and maybe and strep. So eczema treatment. So this is most of the stuff you can do at home to start with. So the key to eczema treatment: moisturize, moisturize, moisturize. People don't like doing it, especially boys, but it is the key to eczema care. My favorite over-the-counter moisturizer is Vanicream, but also Cetaphil, CeraVe, Aveeno, Aquaphor, all good ones. You want to use a mild, soap-free cleanser. You don't want to damage that skin barrier anymore. So Dove Sensitive, Cetaphil, Aveeno. I like the Aveeno fragrance-free body wash a lot. And that's the big thing. It's okay to bathe every day. People go in these cycles of bathing where bathing is good, it's not good. A daily bath is okay as long as you use a very mild cleanser and don't use too hot of water, because if you heat the water up above body temperature, it starts kind of melting away our natural oils. And you don't need too long of a shower or bath either. But so start with that daily moisturizing, good skincare. And then if you're not controlled, you then go to a topical steroid. You can get 1% hydrocortisone over the counter, and it's pretty effective for mild eczema. But once it gets more moderate, severe, it's not going to be enough. So then you can go to a 2.5% hydrocortisone, or what my mainstays are. I like to use a lot of triamcinolone and mometasone. Those are medium potency steroids. So the eczema we saw in those pictures, you're going to have a prescription steroid. And I like to do it daily until better. So maybe like 5, 7, 10, even 2 weeks of daily use till better, and then back off and do it as needed. You don't want to do steroids long-term because you can have thinning and atrophy of the skin and stretch marks. And once you get stretch marks, it's irreversible. So use it when you need it, but as soon as the skin is better, back off. I like to do what's called proactive therapy too. I'll do it for several days in a row to get it better, and then I'll treat the skin twice a week to prevent those flares. So these are all good moisturizers. I like Cetaphil, CeraVe. We're kind of moving away from the parabens that are in some products, and so we're kind of going paraben-free. There's some concern that they may cause problems. I love the Aveeno cleansers, and this is one of my favorite. If I had to pick one, I would say Vanicream is my favorite moisturizer currently. Now, once you get past the topical steroids, then we can use what's called calcineurin inhibitors. There's tacrolimus and pimecrolimus. There is an FDA warning on these products that says there could be a potential risk of skin cancer or lymphoma. It's never been shown in humans. That was based off some animal studies with IV usage, because these same medicines can be used for things like kidney transplants in a very high IV dose. But topical, we think very safe. So we have Protopic and Elidel. These are approved for age 2 and up. And I really like these for the eyes. We had questions about eyelid dermatitis. So if someone has eyelid dermatitis that's eczema, I really like using either the Elidil or Protopic, pimecrolimus, tacrolimus, and I'll use a low potency steroid, like a 2.5% hydrocortisone, or maybe a desonide. But also with the eyelid dermatitis, it's very common to get a contact dermatitis. In women, one of the most common causes is nail polish. So acrylic nail polish, touch your face, you cause it. Or hand sanitizers or soaps, makeup, all those can cause eyelid dermatitis. Also for eczema, we have crisaborole, which is, it's a very expensive medicine. It can cost like $500. Eucrisa, it's called. And I would say it's about as effective as maybe like a 1% hydrocortisone. It can sting and burn. So it's mildly effective, super expensive, it can be irritating. Not my favorite, but in some people that they do well on it, and there's no steroid side effects. Light therapy can be helpful. I don't do it personally, but dermatologists can do that, and it can help. Wet wraps, I'll show you a picture in a minute. Wet wraps are like my kind of hidden gem of treatment. I love doing wet wraps on people to help severe eczema. And our latest thing, about, I guess, 2 years now, we have Dupixent or dupilumab. It's an injection that binds and activates interleukin 4 and 13. So this gets back at the underlying allergic inflammation of eczema. And it can have an amazing response. Like within a week or two, you can see the eczema melt away. Now it's super expensive, $40,000 a year, and it doesn't cure it. It just controls it while you're using it. But it can be life-changing for some people. So these are wet wraps here. This poor little guy had bad eczema. And then what you do is you soak him in the bathtub, you get out, you put the medicine on, the steroid, moisturize him with your Vanicream or whatever, and then wrap him in moist pajamas or moist gauze. Leave it on for a couple hours. Got to keep him warm with, some cuddling is great, a big blanket, a dry pajamas over it. After a few hours, take it off, reapply the moisturizer, and it can really help eczema in the short term. Okay, and then speaking of wrap, so kind of wrap it up here. So some take-home points for eczema. Really focus on the skincare. Mild cleansers, once a day moisturizing, not too hot of bath or showers, avoiding irritants. And the only medicine you can really get that's helpful is 1% hydrocortisone over the counter. After that, you're gonna have to see your physician about a prescription medicine. For allergic rhinitis treatment, many more options. Really stress using a nasal steroid for at least 2 weeks at a time. And then you can use the oral antihistamines as needed for itching and the eye drops for the eye symptoms. And if not controlled with that, you can see your doctor about a nasal antihistamine or think about seeing an allergist for skin testing. Okay, we have a few more questions up here. Let's see. So what allergens cause headaches? So headaches it's tough because we don't always know if the headaches are from your allergic rhinitis or not. But people that have a lot of congestion, they may get some sinus headaches and pressure headaches. So what I like to do is if someone's having those sinus and pressure headaches, I make sure they're on a nasal steroid, and then maybe short course of Sudafed if they can tolerate it. But if they're having like nausea, vision changes, then I think about migraines. And there you might get a migraine specific medicine like sumatriptan, or you may need a preventative medicine like amitriptyline, Topamax, a beta blocker. And migraines can actually cause nasal symptoms. So they can actually activate the nerves around your nose. So it's a pretty tough thing to differentiate sometimes. So what is the best treatment for chronic or constant drainage? If it's drainage out the front of your nose, the ipratropium is very good, only prescription. If it's drainage in the back of your throat, there start with the nasal steroid every single day. And if not controlled, add in the nasal antihistamine. So is direct sunlight helpful for eczema? It can be, but it's very hard to get the dose right. So you're much better off probably seeing a dermatologist for phototherapy for severe eczema. Now, for mild eczema, sunlight, we always have this balance of the skin cancer versus, helpful sunlight and vitamin D. There is some evidence that children in Mongolia, northern Mongolia, get very little sunlight, short days, that they've increased eczema. So it is thought that maybe vitamin D regulation and sunlight is actually pretty good, but you don't want to overdo it. So I think moderate sunlight is probably good for a lot of things. But then you have to balance out the risk of skin cancer, of course. So you don't want to burn. In terms of treating like severe eczema, I wouldn't go the sunlight route there. And I really try to stay away from tanning beds for the skin cancer problem. But some people who have bad psoriasis or even eczema, they have found that self-tanning can help. But again, I don't recommend that. My kiddo has horrible drainage, Flonase or nasal spray. So if a child is 2 years or older, I would recommend a nasal steroid for bad drainage, and that's going to work better than an antihistamine. If they do, use an oral antihistamine, I think Zyrtec is great. It's my go-to, but some like Claritin or Allegra better. But also, this may not be allergic. It may be daycare infections, other viral infections, so it can be hard to know. Can allergy cause ringing and pain in the ear? So it can cause what's called a station tube dysfunction, where when you have swelling of what's called the posterior nasopharynx, that's where the eustachian tube opens up in the back of our nose, then the air in the middle ear, it gets absorbed, and it feels like the eardrum is getting sucked in, because it is, like you're underwater. And that can cause some pain and discomfort and even auditory changes. So you want to be able to open that eustachian tube back up using the anti-inflammatories like the nasal steroids, maybe a short course of Sudafed. So ocular rosacea. So I actually have some of that. Totally different topic. So it's unrelated to allergies, but some people think that for ocular rosacea that doxycycline can help, and they even sometimes will use some drops, like some anti-inflammatory drops. So that's something you want to definitely talk to your eye doctor about. But maybe oral doxycycline would be one of the best. Is loss of eyelash a factor of eczema? So kids who have bad eczema, especially eyelid dermatitis, they will rub their eyelashes out. So we see that. So we really want to avoid that rubbing and scratching because it traumatizes the eyes and it makes it worse. There's kind of a wives' tale. Some think that long eyelashes are a sign of allergies, but no real proof. So would Dimista be a good option for a child who takes Claritin and Flonase for environmental allergies? So if they're over 2 and they're not controlled, you could try Dimista. Again, that would be Flonase and Astelin. It's only prescription. And do it twice a day and see how it works. And it should be pretty safe and effective. So can you speak on oral allergy syndrome? So oral allergy syndrome, the term we use now is pollen food syndrome. And you get sensitized to a pollen, like birch is the classic one. And the same proteins in birch is in apples, peaches, pears, cherries, and several others. So when you eat that fresh fruit, it feels like you're eating pollen in essence because the same protein's there. And wherever it touches, it causes histamine release in your mouth and throat. So you get itching of your mouth, some irritation, your throat can feel tight, make your lips swell a little bit. Now, luckily, when you eat it, your stomach breaks down that protein. So you're not getting anaphylaxis, like a peanut allergy, because it's a very heat enzyme labile protein. That means that when the acid in your stomach, the enzymes, they break it down. But whenever you eat a fresh apple, it can be pretty miserable. You're so itchy. But if you cook it, it's okay. Cooking denatures the protein. So apple pie, pasteurized apple juice, cherry pie is okay. But if you do it fresh, it'll cause those problems. Sometimes getting allergy shots to the underlying pollen, like birch, can make it better. Also, ragweed cross-reacts with bananas and melons. And then grasses can cross-react sometimes with like celery and citrus. But it's nothing to do like with the pesticides or pollen on the fruit. It's actually the same proteins in the flesh of the fruit cross-reacts with the pollen because it's a very important or efficient pollen for that those plants, and when it's it's passed down in these kind of closely evolutionary related plants. Okay, well, that is it. So I think we're finishing up just in time, and thank you very much for attending. Hopefully it was helpful. Any questions, please contact your regular doctor if not controlled, or you're welcome. I'd love to see you as well. If you have any help, you can just check through Prisma.
Thank you so much, Dr. Amril. This was so informative for everyone. Thank you all for joining us for today's event. As I mentioned before, it is our last event in our Spring into Health series with Prisma Health. So I do just want to give them another big thank you as well. And you all can take a look at ufscalumni.org/events for more events we'll have coming up. We'll be doing a little mini travel series virtually this summer. So keep an eye out for that if you're interested. But thank you again, Dr. Amril, for your time.
You're welcome. Thank you all, and have a good day. Bye.